Hello and welcome to this lecture. In this session, we will discuss tuberculosis. We will discuss the pathophysiology, clinical features, mode of transmission, and treatment options of tuberculosis. Tuberculosis is a deadly bacterial infection that has taken lives of billions of people. It has affected around 1/3 of the population. It is of three types: primary tuberculosis, secondary tuberculosis, and miliary tuberculosis. Primary tuberculosis can occur in chest, in abdomen, in kidneys. Secondary tuberculosis occurs when there is primary tuberculosis that has been latent for years. Miliary tuberculosis is due to the hematogenous spread of the tuberculomas. Not everyone acquires this disease, tuberculosis. So there are some risk factors that are associated with the acquisition of this disease. These risk factors include malnutrition. Malnutrition causes tuberculosis because it decreases the immunity. When there will be decreased immunity, we can acquire many different diseases, including this disease of tuberculosis. Household exposure. When a person, that is your family member, acquires this disease, there are increased chances of spread of this disease. In the prisoners, tuberculosis is a common disease because there is overcrowding. Drug use. Tuberculosis is most frequently seen in people with IV drug abuse capacity. In an area where tuberculosis is endemic, the word endemic means that a local area that is affected by a particular disease. So when you travel to an area that is endemic of tuberculosis, there is a great chance that you can acquire tuberculosis. Overcrowding, infections. When a person is already chronically affected from any disease or he is immunosuppressed due to any infection, then there is a large chance that he can acquire tuberculosis. One of the example is that patients who are suffering from acquired immunodeficiency disease, that is also called AIDS or HIV, there is large incidence of tuberculosis in such patients. Tuberculosis is spread with the help of aerosol droplets. The aerosol droplets are produced when a person coughs or sneezes. Mycobacterium tuberculosis, that is the causative agent of TB, is a very small organism, which means you can observe it under the microscope. It is a rod-shaped bacteria, which is also called a bacillus. It contains a waxy cell wall. It is acid-fast. This is because it contains mycolic acid in here. And this acid-fast is responsible for the name acid-fast bacillus, which is given to this bacteria when we visualize it under the Ziehl-Neelsen or Zn staining, which we will discuss in the diagnosis part later on. It is a strict aerobe, which means it needs high quantity of oxygen. So it lives in the upper portion of the lungs that are well ventilated. It produces a protein, which is called Cod factor. This Cod factor is responsible for the virulence of this bacteria. This Cod factor is responsible to prevent the attachment of phagosome to lysosome. So it helps this bacteria affect the organism. The proteins in the cell wall of this bacteria are responsible for giving the results of PPD, that is protein purified derivative test. When the mycobacterium enters the lungs of the individual, it is engulfed by the alveolar macrophages. These alveolar macrophages then form a phagosome around it. In normal individuals, this phagosome gets attached to the lysosomes and it then gets engulfed and wasted. But here, Cod factor is produced. This cod factor prevents the attachment of this phagosome to this lysosome. So these bacteria now escape the microbicidal activity of the alveolar macrophages and they are ready to cause the disease. Here, the stage of primary TB develops. Primary TB can be latent for many years or it can be active. According to the latest researches, around 95% of people have latent TB initially, and only in 5% of people who are immunosuppressed for any reason, this TB appears actively. Now what happens in these 95% of individuals is that granuloma formation takes place. The granuloma that is formed in the subpleural region, it is called gone focus. This gone focus can then travel and engulf the hilar lymph nodes. Then it is called a gone complex. In this picture, you can see the gone focus and the gone complex. The gone focus is present peripherally, whereas the gone complex is a combination of the gone focus as well as the necrosed mediastinal lymph node. We have discussed that the gone focus and gone complex are composed of granulomas. Now let's see what is the structure of granuloma. This is a histological slide of a granuloma. You can see that in the center, this pinkish material is a caseous necrosis. Caseous means cheese-like. So this central cheesy material is because of the excessive waxy lipids that are present in the cell wall of Mycobacterium tuberculosis. It is surrounded by a rim of purplish lymphocytes. Epithelioid cells are modified macrophages and these are the hallmark of granulomas. This is a Langhans joint cell. Now granulomas are of two types, caseating and non-caseating. Here we have seen a picture of a caseating granuloma, which is seen in Mycobacterium tuberculosis infections. It is also seen in infections by some systemic fungi like histoplasmosis. The non-caseating granulomas can be seen in some diseases like sarcoidosis and cat scratch disease. As the granuloma is formed, the next step is calcification and fibrosis. This leads to a permanent scar tissue formation in the lungs. The next type of TB is secondary TB. It is also called reactivation TB because it occurs after the primary TB that has been latent for years gets reactivated. The hallmark of secondary or reactivation TB is called cavitation. This cavitation is produced by the cytokines that are released from the T cells. Now these T cells are the memory T cells that are releasing some cytokines and they are causing this cavitation. This cavitation is a permanent finding that can be seen in the radiograph. Here you can see there is a cavitation that is seen in the upper lobes. Now this all occurs in upper lobes because it is more ventilated than perfused. We all know that there is a ventilation-perfusion ratio in the lungs where the upper parts of the lungs are more ventilated as compared to perfused. As Mycobacterium is a strict aerobe, it prefers to live and infect in the upper lobes of the lungs. When a person gets affected from tuberculosis, he presents with certain clinical features initially. As the disease advances, some other clinical features appear. Now we'll see what are those clinical features. Fever is one of the most common symptoms that are seen with infection of Mycobacterium tuberculosis. The fever is usually low grade, which means it is around 100°F or less. Sometimes evening rise in this fever can be seen. Malaise means a sign of tiredness, weakness, Another symptom is cough. Cough is usually productive, which means sputum is produced. Fatigue means tiredness. A person who is getting infected from this deadly microorganisms feels tired. A person may also exhibit night sweats. Late clinical features include dyspnea, which means shortness of breath, weight loss, hemoptysis, which means blood in the sputum. Now we will discuss some of the complications in the respiratory system that are caused by Mycobacterium tuberculosis. As the inflammatory immune response is produced, it leads to granuloma formation. But rupture of these granuloma can cause release of microorganisms. These microorganisms can invade the bronchus. As it invades the bronchus, it can cause rupture of some of the small capillaries, which can give rise to hemoptysis, which is blood in the sputum. The cavity that is produced by the reactivated TB may give rise to fungus formation. This fungus is aspergillus. So this disease is then called aspergillosis. The damaged lungs can produce bronchiectasis, in which honeycombing of lungs take place. Bronchiectasis is characterized by excessive sputum production. Copious amount of foul-smelling sputum is produced in bronchiectasis. Damage to the lungs causes dyspnea and mucus-producing cough. Now we will discuss the third type of TB, that is miliary TB. It is also called systemic TB because it results from the hematogenous spread of the tuberculomas. When the tuberculosis is spread in the blood, it can damage various organs. In the lungs, it can produce a millet seed appearance, which can be seen on this radiograph. Tuberculosis can produce lymphadenopathy. This lymphadenopathy can occur in the cervical region, or it might occur in the inguinal or axillary regions. The matted, rubbery enlarged lymph nodes in the neck are called scrofula. This disease can advance to the adrenal glands, where it can cause Addison's disease. Addison's disease is a disease characterized by decreased mineralocorticoid and glucocorticoid production, resulting in episodes of hypoglycemia and hypotension. It can give rise to disease in the genitourinary tract, which can cause infertility. In the skin, it can give rise to lupus vulgaris. In the bones, it can progress. It can also progress to vertebrae, causing Pott's disease. When it reaches the heart, it can cause pericarditis. Tuberculosis is the most common cause of constrictive pericarditis. In the brain, it can cause tubercular meningitis, which is characterized by headache, neck stiffness, and it may even lead to cranial nerve damage and coma. The most common extrapulmonary site of spread of tuberculosis is kidney. In the liver, it can give rise to granulomatous hepatitis. The diagnosis of Mycobacterium tuberculosis cannot take place under an ordinary microscope. It requires some of the essential stains for diagnosis of Mycobacterium tuberculosis. Let's see what these are. The diagnosis of Mycobacterium tuberculosis occurs using AFP staining. This staining is called Ziehl-Neelsen or ZN staining. Sputum cultures can also be taken. These sputum cultures cannot be grown on ordinary culture medias. A specialized culture media that is called the Lowenstein-Jensen media is required for the growth of Mycobacterium tuberculosis. Treatment of Mycobacterium tuberculosis involves the first-line agents and the second-line agents. Second-line agents are only used when the first-line agents fail to cure the disease. The medication of Mycobacterium tuberculosis eradication is very difficult to take because it consists of many medications and a prolonged duration of 7 to 9 months. Directly observed therapy or dot therapy is a technique in which the general practitioner or the clinician gives the medication to the patient in front of himself. Due to uncompliance of the patients, many drug-resistant strains have appeared. Now we will discuss the first-line agents. These are the antimycobacterial drugs that cause the damage to the DNA of the mycobacterium. These include isoniazid, which is also called INH, ethambutol, rifampicin, pyrazinamide, streptomycin, and pyridoxine. The most effective ones are isoniazid, ethambutol, and rifampicin. Pyrazinamide and streptomycin are important because they cause decrease in dose of the first three mentioned drugs and decrease the risk of adverse drug reactions produced by isoniazid, ethambutol, and rifampicin. Pyridoxine, which is a supplement of vitamin B6, is given to reduce the toxicity of isoniazid. Isoniazid reduces peripheral neuropathy and optic neuritis by killing the enzyme that causes the formation of vitamin B6. This is the reason why pyridoxine is given as a supplement, because patients who are taking these drugs cannot produce their own vitamin B6. Isoniazid also causes hepatitis. Ethambutol. Ethambutol is famous for optic nerve damage. It can cause visual field defects and color blindness. Rifampicin gives a reddish color to the urine, which can be mistaken for myoglobin or hemoglobinuria. It also causes hepatic damage. It can cause enzyme induction, and this is responsible for drug reactions with other drugs. Pyrazinamide causes impairment of liver function. It can also cause hyperuricemia, which means increased level of uric acid that can cause gout. Streptomycin is responsible for oto and nephrotoxicity. Oto means ear, so it damages the inner ear and the labyrinth. Nephro means kidney, so it causes toxicity in the kidneys. Lastly, pyridoxine, which is given as a supplement to decrease the toxicity caused by isoniazid. You can remember this with the help of a mnemonic called RIPES. R-I-P-E-S. R stands for rifampicin, I stands for isoniazid, P stands for pyrazinamide, E stands for ethambutol, and S stands for streptomycin. As the resistant strains have emerged, we need to use some second-line agents. These include amikacin, clarithromycin, fluoroquinolones, kanamycin, and capreomycin. All of them are antibiotics and some of them are injectable. Due to the uncompliant behavior of the patients, multiple drug-resistant strains have emerged. This resistance can be due to the interference with mycolic acid or an enzyme called catalase peroxidase. The drug-resistant TB can be MDR, which means multi-drug resistant TB, which is resistance to isoniazid and rifampicin. XDR-TB is the extensively drug-resistant TB. It is an infection that is resistant to isoniazid, rifampicin, and second-line agents. Some new agents are now available in market that have been tried and tested on the patients. These include bedaquiline, pretomanid, and linezolid. They can be used separately or as a combination for a long period of time to cure these patients. To summarize what we have discussed so far, Mycobacterium tuberculosis is the causative agent that when enters the lungs forms the Ghon focus and Ghon complex. After the granuloma formation, scarring and calcification takes place. In the secondary TB, this granuloma ruptures. The organisms then travels and forms the cavitation. If hematogenous spread takes place, it gives rise to miliary TB. The diagnosis is with the help of Zn stain or LJ culture media. The clinical features include fever, cough, hemoptysis, fatigue. The complications can vary depending upon the organ systems. The treatment options consists of the first line and the second line agents along with some newer agents. So that was all from me, Dr. Mariam Malik. For more